Hello again. As continuation of the anatomy of the alimentary tract, this session will be like a continue for the anatomy of the intestine, as we talked previously about the anatomy of the small intestine, and we stop for a while to talk about the anatomy of the accessory glands of the GIT. Now we will continue of the anatomy of the large intestine, and this session will be the anatomy for the colons, the large intestine, transverse colon, ascending and descending colon. At the end of this session, you will be able to describe part of the large intestine and describe feature of the large intestine, to discuss some critical correlation and describe blood supply, nerve supply of the large intestine. Large intestine is subdivided into the cecum, veriform appendix, colon, rectum, and anal canal. This session will be mainly for cecum, appendix, and colon, and there will be a separate session for rectum and colon. A special feature of the large intestine, when the large intestine that distinguish it from the small intestine, we could find something called tena coli, the thickening of the longitudinal muscle band that found in the small intestine, and also there is an hastration or circulation, peckering created by tena coli, and we also have something called epiploic appendicitis. This is a fat-filled pouch of visceral peritoneum. This is mainly three features that distinguish large intestine from small intestine. As you can see here, this is a fat-filled pouch, omental appendicis or appendicis epiploici, and this is a thickening of the muscle bands called tena coli. Here also, you can see here, transverse colon, ascending colon, appendix, and also very clear here, transverse mesocolon. You can see appendicis epiploici and part of the ileum ileocecal valve, and transverse colon, superior mesenteric artery. Those all can be seen here in rectum and in the canal. Cecum is a blind pouch beginning of the beginning of the large intestine, and the part behind the cecum you can find different position for the appendix. It contains lymphoid tissue to neutralize the pathogens. The colon is divided into the distinct segments. We have ascending colon, transverse, descending colon, and sigmoid colon. Here, this is a view for the appendix and cecum. As you can see here, the cecum, appendix, a part of the terminal ileum, small intestine, and the sphincter, ileocecal valve. Appendix or veriform appendix is a blind-ended tube connected to the cecum. During the early years of development, the appendix has been shown to function as a lymphoid organ. Appendix is a great variable in position, as I said. It has a different position. This is the most common position of the appendix. You can see an appendix retrocecal position, subcecal, paracecal, pelvic, periileal, both ileal, and can be subhepatic. And according to this position, if appendix has been inflamed, the symptoms that can be the patient presented with can be different, and to explain the position of the appendix for those with the pelvic appendix can cause irritation of the rectum and maybe causing diarrhea and something like that, and those of the retrocecal can irritate the psoas muscle, also causing the flexion of the hip muscle on the side. here, and this is anatomical landmark or surface anatomy of the base of the appendix during surgery. This is very important for you to know this. During surgery, you would like to make an incision at this point, either great iron incision or lance incision, and this point is called McBurney point. It's a joint between the umbilicus and the anterior superior iliac spine, the lateral one third. The colon, we have ascending colon. It is completely retroperitoneal organ from the cecum to the right lobe of the liver, or it's called hepatic flexure. Transverse colon is a start from hepatic flexure to the splenic flexure. Splenic flexure is less mobile and anterior to the left kidney, attached to the diaphragm by a pharyngocoelic ligament, attached to by mesocolon. This pharyngocoelic ligament prevents the spleen to descend down into the left side and to direct to the right side. Here it is very clear and obvious. We can see here the appendix, the part of the small intestine ileum. We have the blind pouch, the cecum, then the tinea coli, ascending colon, and the appendix obliqui. Also the right colic flexure, transverse colon, left colic flexure, and there is also the something about the fissure of the large intestine. The haustration or circulation can be seen here very clear, and then going down to the sigmoid colon, rectum, and anal canal. This is a very nice picture showing the part of the large intestine. Descending colon is also retroperitoneal. It started from the splenic flexure to the sigmoid colon and pass anterior to the lateral border of the left kidney. Sigmoid colon, from its name, it is like S-shaped lobe, variable in length, and linked descending colon and rectum. At the end of the started the rectum of the S3 vertebrae as a long mesentery is called sigmoid mesocolon. One of the most important things is the valvulus. You can see here this is a segment shape or coffee bean sign. This is an indication that has a sigmoid colon or loop of the large intestine has been twisted and appear like this, and this causing the bowel could be not healthy, and all of them can be necrosed and need urgent surgical intervention. This is a part of the acute abdomen. This is sigmoid valvulus. You can see it very clear on the barium enema or in the abdominal X-ray. It seems like segment shape or coffee bean sign. The signs could be the obstructive symptoms like constipation, then ischemia and necrosis, and the complication, if not treated, could be lead to the perforation or fetal peritonitis. Here it is very clear, coffee bean sign here in the X-ray. Blood supply, here is the abdominal aorta. You can see the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Superior mesenteric artery, it supply the large intestine, and inferior mesenteric artery also supply part of the hindguts. That supply midgut is the superior mesenteric artery, and inferior mesenteric artery supply the hindguts. Here it is very clear and obvious. We can see here the appendix, the part of the small intestine ileum. We have the blind pouch, the cecum, then the tinea coli, ascending colon, and the appendix obliqui. Also the right colic flexure, transverse colon, left colic flexure, and there is also venous drain into the superior mesenteric vein and inferior mesenteric vein. Superior mesenteric vein is joined to the portal vein, and inferior mesenteric vein is joined to the splenic vein, also at the end to join the portal vein. Here, this is a retroperitoneal organ, and this is the barium, and then took by X-ray. You can see the haustration is very clear here or the large intestine, very clear masturbation. Eat any part of the intestine that could not take the dye of the enema, clearly that could be sign of obstruction. Also here, very clear. This is a sausage shape transverse colon. This is a small coil of the jejunum and ileum. It is also very clear. The stomach over there.